Septic shock comprises of an underlying circulatory and cellular abnormality that has an increased mortality. During an effective patient assessment, we can help determine some of the therapies and interventions that can aid our patient and hopefully prevent some of the deadly effects of severe shock or multiple organ dysfunction and failure. Sometimes it's hard to actually assess whether or not our patient is having a severe septic reaction because it all occurs on the microvascular and cellular level, and sometimes they do not manifest in their vital signs or clinical examinations initially.
During our patient assessment of our patients with septic shock, there are certain indications or signs and symptoms we'll be able to see from the bedside immediately with our patient. Very often they will have some type of fever, so flushed skin, possibly diaphoretic. They also may be chilled or have cool skin, also with some form of rigor, meaning they're stiff in their extremities typically. They also may seem confused and extra anxious. They also may or display some sense of dyspnea, meaning they have difficulty breathing. They also may be very fatigued and have an overall sense of malaise or sense of illness. And of course, they may mention to you several times they're nauseous and constantly want to vomit. Keep in mind that in our physical examination, we're going to see evidence of a systemic inflammatory response, and that includes a lot of third spacing where there's some fluid buildup from the cells that's able to push out and make the arms and legs and other body parts swell up, and for some patients even leak, and some of that gets through to the skin even. There's that much edema. So, of course, with septic patients, there's a source of infection, and certain locations of those infections can cause certain types of signs and symptoms. So, for head and neck infections, there may be severe headache, neck stiffness, altered mental status, earaches or sore throats, spinal pain. And for some patients, if they have a chest or pulmonary infection, they just feel a lot of extra chest pain. They have a lot of coughing, productive cough typically. And, listening to your patient breathing, you're going to probably hear rales, possibly some crackles. You're going to hear the presence of bronchial sounds, like there's not a lot of air movement getting deep into the lungs, especially due to any extra secretions or consolidation. And if you're doing a little IPPA, you're more likely going to hear dull percussion notes from their lungs. Now, for patients who have a cardiac infection, that ultimately just indicates that there's possibly a new type of murmur in their heart that needs to be investigated and rectified if possible. There's also, of course, gastrointestinal infections. These can include the causes for diarrhea, abdominal pain, extensive tenderness, and some dysuria, meaning they're just having difficulty passing urine. There also may be bone and soft tissue infections, and these are pretty extensive. These are widespread pain and tenderness locations over the body. There's also typically a large amount of edema, as well as some joint effusions. And of course, skin infections are a very common one that can come from all kinds of things. And for this one, you might see petechiae, or that red spotting over the skin, some purpura, which looks like widespread bruising, and ulcerations, which just seems like the skin's kind of opening up and oozing, and it's kind of wounded and torn. And so these different types of signs and symptoms we see from assessing our patient give us an indication of what may possibly be the cause. And of course, knowing the cause helps us know how to treat our patient. So, of course, we're going to look for laboratory findings from a complete blood count, seeing what kinds of information we can get from their blood. So, especially wanting to know for septic patients, what is their differential? How high or how low is their white blood cell count, telling us how well or how poorly their body's fighting infection. We also will do a coagulation study, or look for one. That will include, of course, prothrombin and fibrinogen, and seeing how well their blood is clotting and functioning still. We'll of course look at the blood chemistry. That's the sodium and chloride, bicarb, glucose, and lactate levels. And more than likely, those will all fairly be increased for those patients. The bicarb might be a little bit lower though because of the stress that they're in. But we're also going to look at their kidney and liver function. We're going to see some blood cultures hopefully done as well. And a urinalysis more than likely will almost always happen. We want to see if there's something that's coming from their kidneys or liver that we can possibly identify as a source, or as a type of culturable bacteria that we can identify and see if we can find an corresponding antibiotic to kill it. And of course, sputum culture, especially if it's a pulmonary disease, we want to be able to assess that and directly address that um, for that patient. So, of course, there's also diagnostic findings. This will include chest and abdominal radiographs or x-rays. And I've included one here for you all to look at. You'll see there's so much of that lung that's not black, it's whited out, meaning there's so much, fluid or infiltrates and things that are not pertinent to healthy breathing that are sitting in that patient's lung due to an infection. An infection creates more swelling, more fluid, more bacterial, and preferable environments for it to grow and replicate. And you can see that in an X-ray. It's an excellent form of identifying just how extensive some of that bacteria has modified the anatomy for that person. We also have abdominal ultrasonography. This will help especially if there's a bowel obstruction or perforation. Maybe that's caused some tissue to die, or to be so obstructed it's become ischemic. It's not, getting any blood flow, and it's beginning to become infected from that. We can also see if there's any peritonitis, or we can even evaluate the heart from there. Patients may also get computed tomography, and this is especially indicated if there is a retroperitoneal infection, an ischemic bowel, like we mentioned, there's no blood flow to part of the intestines or bowel region, or appendicitis. And then finally, especially if it's an issue with spinal cord or brain infection, we're going to probably have a lumbar puncture done for that patient, and that allows us to look and see if there's any form of meningitis or encephalitis or any type of inflammation from a toxin or bacteria that's gotten into that critical area of the body. Now we're ready to look at the hemodynamic monitoring of our patient. It is very important to monitor the cardiac pressure, non-invasive blood pressure, and pulse oximetry as well. But in septic shock patients, their hemodynamic pressure tracings can indicate that they may have an increased heart rate, decreased pulse pressure, decreased blood pressure, increased systemic vascular resistance, as well as a pulmonary vascular resistance and central venous pressure, and an increased pulmonary artery pressure, and an increased pulmonary artery wedge pressure. There also may be decreased cardiac output and decreased central and mixed venous oxygen saturation. Remember that these are very generalized rules for patients in this state, but these are fairly common trends to see upon hemodynamic monitoring tracing. Treatment plans for septic patients include first antibiotic therapy, second resuscitation, and then corrective hypoxia, hypotension, and hypoperfusion measures, third infection source control, including possible surgical removal or drainage, fourth, to interrupt and stabilize possible multiple organ dysfunction syndrome, and 5. Proper ventilation management according to an ARDSNet protocol. Our first medical drug is aspirin, which is an effective fever reducer and can also help regulate our patient's body temperature. We also will distribute isotonic crystalloid solutions such as normal saline. This will help increase intravascular volume. We also will give norepinephrine, which is a potent vasoconstrictor and will help increase muscle contractility and increase the blood pressure. We also have epinephrine, which increases the mean arterial pressure, cardiac index, stroke volume, systemic vascular resistance, and heart rate. We also may give phenylephrine, which is a potent vasoconstrictor as well, and will also help increase the blood pressure. We also have the option of using vasopressin, which is an antidiuretic hormone. Dopamine is not really indicated, and nor is it really recommended in this case for septic patients because it creates unfavorable flow distribution and may increase the chances for arrhythmias in the patient. Heparin may be given because it may increase the peripheral perfusion available for the patient's tissues. Patients may also receive a corticosteroid called hydrocortisone, and this will help stabilize the cell. It also helps stabilizes the lysosomal membranes of the cells and help improve pulmonary microcirculation. Another corticosteroid is dexamethasone. We also have several antibiotics, and I won't tell you about all the differentiations between them because they virtually all do the same thing. They attack gram-negative or gram-positive bacteria, and they are also very effective in systemically widespread infections like for septic patients. So that includes, I'll do my best to pronounce these, cefotoxamine, timitin, piperacillin, imipenem, meropenem, clindamycin, metronidazole, ceftriaxone, cipraloxin, cefepime, levofloxacin, and vancomycin.
Septic patients often have a metabolic acidosis. This is also indicated by their decreased oxygenation and hypoperfusion. Their blood gases will look like a decreased pH, a rising CO2, decreased oxygenation or PaO2, and a decrease in bicarbonate.
As patients develop infection and the severity of shock increases, early intubation and mechanical ventilation can be life-saving even before signs of respiratory distress or respiratory failure. This is because the initial treatment includes the support of respiratory and circulatory function, supplemental oxygen, mechanical ventilation, and volume infusion. In fact, direct tracheal oxygen administration of 100% via an endotracheal tube has proven superior to the administration via a non-rebreather oxygen mask. With adequate sedation, mechanical ventilation can eliminate the work of breathing and significantly decrease the metabolic demands of breathing. However, the repetitive alveolar overdistension and opening and closing of the alveoli can increase the risk of acute respiratory distress syndrome. This requires low tidal volumes and increased respiratory rates with goals of plateau pressures at or below 30 millimeters of mercury, and of course, PEEP is utilized according to the ARDS-NET protocol. All of this is an effort to limit or minimize lung damage and oxygen toxicity, allowing injured lungs to heal and tissues to better oxygenate.